Hello everyone, Michelle Lyons here. I am delighted to welcome my learned colleague, Ms. Fiona Rogers, to talk about her insights into how electrotherapy can really help us work in pelvic health with a little bit more efficacy. In the Facebook group Global Pelvic Physio, we get a lot of questions about electrotherapy, about things like, is electrotherapy suitable for things like fecal incontinence or urinary incontinence? How can we use vaginal weights? How can we use sacral neuromodulation? Does it really work? So my go-to expert on all of these is I always end up tagging Fiona. So I thought it would be really valuable to pick her brains here for a couple of minutes and see what are her thoughts on current strategies for really helping to use electrotherapy in a more effective way. So welcome, Fiona.
Hello, how are you? And if I start going off on a tangent and nodding my head, the internet's telling me it's a bit unstable here, and Michelle, you're just dropping out every now and then. So sorry if I start talking about something that you haven't actually asked me about.
So Fiona, do you want to just introduce yourself to those people who are not aware of your genius?
My genius, thank you. That's a very kind thing to say. Yeah, hi, I'm Fiona Rogers, women's health physio from Down Under in Australia, and I run with my husband the pelvic floor exercise website where we sell pelvic floor devices and resources. So I guess I still do a little bit of clinical work. I've been a physio for longer than I care to admit, my interest in STIM really, we learned it at uni all those years ago. I come from the dinosaur ages when all electrotherapy was taught and used, and then we went through that whole you mustn't lay hands on patients, etc. And all electro is bad. And I think that pendulum is swinging back a lot these days. And I certainly use STIM occasionally with my patients. And then when we took this website over, we were selling STIM machines. So I kind of piqued my interest in looking more into the research behind it and how well it worked for various conditions. And so it was a big learning curve for me. And it's actually an interest that I'm quite passionate about now, because there is, loads of research out there. And most of the clinical work that I do now is I'm very, very fortunate to work with two excellent pain specialists. So, they're at the other end of the scale looking at neuromodulation, etc. And so, I've learned a lot from them as well. And that kind of piqued my interest even further to look into it more. So, and of course, I have to know answers for people when they ask, what does a machine do and why and how and so forth. So, that's where my interest has
led
been sparked, really.
What I thought was really interesting was that when I was over teaching in Australia, New Zealand and Singapore with you earlier this year, we were trying to bring in some aspects of some current thinking about electrotherapy, because it has kind of swung in and out of fashion in physio quite a bit. I think people are really unaware of how useful it can be as an adjunct. And if you think about one of the kind of the most common things that we're going to see in terms of pelvic health is going to be something like incontinence, whether we're talking about urinary incontinence or fecal incontinence. So I was just wondering if you could maybe share just briefly some of your thoughts on how we can best use STIM for that.
Absolutely. And I think to look at the current where we're sitting currently with the mesh debate or debacle, whatever you want to call it. And we're going to be, a lot more women are going to be seeking conservative treatment. And I think, that's where we as physios can probably shine a little bit more, because a lot of women who would have bypassed conservative and gone straight to surgery, I mean, obviously a lot of women do require surgery, but, there is that percentage that probably would have done really well with conservative treatment. So I think we actually have to step up to the plate a little bit more with our conservative treatment. And certainly perhaps maximising the use of STIM in the appropriate situation will be something that we need to look at. And because of this whole range of, is it taught, isn't it taught, in and out of fashion, there's certainly a large number of physios out there who just were never taught how to use it properly. Most people I find are taught, well, these are the programs on the machine. You have to use this one for stress incontinence, this one for OAB, etc. And, you know, a lot of manufacturers sell their machines based on, you need this machine for stress incontinence, you need this machine for overactive bladder, etc. And it just all comes down to the parameters. And you've got to understand the parameters that you're using, and you can tweak them. And I think a lot of people don't understand that. They think they just have to use program 3 for this or program 4 for that. And when it doesn't work for a patient, they just discard it completely and say, well, that didn't work, so I'm not using it. So it really comes down to understanding the parameters that you're using and learning how best to tweak them. So, you know, are you looking at strengthening muscle? Are you looking at calming things down? You know, and at the end of the day, it's all neuromodulation. You know, we you know, people talk about sacro-neuromodulation, etc. Anything you do with a stim machine is a form of neuromodulation. So we're kind of doing it from the very conservative side of things. And then obviously if that doesn't work, we need to look at things, you know, more in a medical term. But and it's never the only treatment that I would recommend. It's always part of a treatment. So for example, with fecal incontinence, it can certainly be a great adjunct. But you've got to look at all the other factors as well. You know, you've got to look at what's happening further up in the gut. You've got to look at, you know, stressors, constipation, you know, your favourite topic. You know, there's so many other, you've got to be doing all of that other stuff. You can't just, if you've got someone with fecal incontinence, for example, you can't just whack a sacral TENS on them and expect it to fix them if they've got a, you know, a type 6 stool every day. You've got to look at those other factors as well. But certainly with things like sacral, if you're not getting anywhere with fecal incontinence, you can add in some sacral, or even using a tibially, Sunday night here, sorry. And well, we call it TTNS, and I know there's a big thing about PTNS and TTNS, and transcutaneous tibial nerve stimulation is TTNS, and generally PTNS is the percutaneous, which is done with the needles. But you will see a lot of people calling it PTNS because in some anatomy books it's called the posterior tibial nerve, or in other books it's called the tibial nerve. So, you know, I think there's a big misunderstanding there. So percutaneous is with needles, but certainly, and I know in different parts of the world people sometimes use needles. Certainly in Australia here we don't. So, you know, basically what you're doing, when you get to the point of using sacral neuromodulation, they're implanting a modulator in, and they're putting the internal leads in. Yeah. The step back from that is doing it sacrally, as we can with a TENS machine, or doing it on the tibial nerve. So you're just doing it from a distance. And we can get quite good results with that, without having to go, you know, to the end line sort of stage.
Can we just talk about electrode placement then? Where do you feel is the best place for electrode placement? Do you go sacrally? Do you like to bring in the tibial nerve?
Sacrally. The closer you can get, the better. So if you're going sacrally, you're trying to get it around S2 to 4. So it's actually a lot lower. If you look at your anatomy, that's actually a fair bit lower than a lot of people seem to think. I've certainly used it tibially on the tibial nerve for people who either can't place it sacrally themselves because of mobility issues, or people who have just got a whole thing about don't want to go anywhere near that area. You can, I mean, you're going up through the tibial nerve into the sciatic nerve, into the S2 nerve root. So, you know, you can modulate from a distance and then work it up to doing it sacrally as well. So, you know, there is some good research showing that. Time frames can be quite different in different research. You know, some of them are up to sort of 4-6 hours at a time, which, you know, isn't always practical. But, you know, doing it for a couple of hours at a time, even an hour at a time, can be very, very helpful. And, you know, you're looking at those lower hertz levels, lower frequency levels. About 10 hertz is the recommended level at maybe sort of 200 pulse width. Okay. So that's the general recommendation for fecal. Pretty much the same for overactive bladder. Again, you can access it from the, you know, that's where we're more traditionally used to using it on the tibial nerve, is for OAB. Certainly you can use it sacrally, and we're looking at the same sort of parameters for trialling it there.
In terms of intensity, Fiona, how strong do you want that intensity to be when you're turning it up?
Well, you don't want to be getting any contraction, so you just a comfortable. If you're doing it on the tibial nerve, you actually need to take it up to the level where you get some contraction,
Okay.
to make sure you're actually on the right spot, so that you're getting some, some toe curling, and then you drop it back down to a comfortable level because you don't want someone with a tetanic contraction happening in their, plantar flexors whilst they're having the treatment. So it's knocking it back intensity wise, so that you're not getting muscle contraction. So just a nice, gentle, comfortable level for that.
And I think, you just really raise an interesting point, because if we're talking about, like the humble TENS machine, can do so much. We talked when we were doing the pelvic pain courses, about the role of TENS in terms of managing dysmenorrhea, in terms of managing endometriosis pain, particularly when we talked about the risks associated not only with opioids but also with NSAIDs.
NSAIDs, yeah.
You, I thought,
absolutely. So, and also, if you're talking overactive bladder, you've got the, the long-term risk of using the drugs that we use there as well. Some of them contribute to dementia. So, I think there is a big part for it to play.
I just saw a thing this morning in one of the medical news bulletins about some of the drugs that they use for interstitial cystitis, bladder pain syndrome, Almiron, causing some sort of macular degeneration. So I think, the beauty of a TENS machine, is that it's cheap, it's portable, it's non-invasive, and if it doesn't work, you just turn it off.
Absolutely.
As opposed to a sacral implant.
Well, exactly.
And I thought when we were teaching, Fiona, you raised some really interesting points about the benefits of maybe using something like an obstetric TENS for endometriosis or period pain. In terms of pelvic pain management, have you found TENS it's undergoing a little bit of a renaissance almost in terms of popularity with that, or have we still got a bit of work to do?
Absolutely. Yeah. Oh, look, there's a lot of work to do, but I think, your points that you said, it's non-invasive, it's cheap, it's easy to do, and it's non-drug based, and if it's not working, then you just turn it off and you try something else. So there's no, the only side effect essentially is that you might get some irritation where you've got the adhesive pads stuck to the skin. So absolutely, I think it's certainly worth it for pain. Again, you can be using it at any point along the nerve pathway or the dermatomes. Sure. Talking about using something like the obstetric TENS that has the plunger, a lot of I'm getting a lot of reports back from physios saying that they're getting good results with that, because women can use it, have it on that low level, and when you hit the boost, it takes you up to that sort of 150 level that can just help with the whilst you're having a cramp or an increase in pain, and then you can drop it back down again. So there's lots, and there's a few other little ones on the market. The only thing I'm not so keen about some of those is that you can't change the parameters, and that's my big thing. If your parameters aren't working, you can change them.
Yes.
So and you can work with them. You can work with your pulse width. You can target it more deeply or more superficially, and again, that's something that a lot of the manufacturers, as I was saying before, they sort of sell a machine based on, this is for period pain, this is for stress incontinence, etc. But if you know what you're doing, you can play with those parameters and basically make it work for you.
Absolutely, I think it's I think in the current climate, when we talk about the risks of surgery, the risks of certain medications, I think this is a really underutilized, and I'm hoping that the pendulum does start to swing back and hopefully settle in the middle when it comes to education around electrotherapy, and that clinicians are confident in terms of exploring options with frequencies and pulse widths if they understand the physics behind it.
Absolutely.
I do think it's also important, that, we mentioned kind of stim very briefly in terms of, and that's maybe what we think of, that 50 hertz, getting that nice contraction if we're talking about something like stress incontinence. But to remember as well that for situations like overactive bladder, that stim can be quite useful for that as well, where you're not directly looking for that kind of, active contraction of the muscle. Have you found that to be a useful strategy?
I lost you a little bit there, but Are we talking about using it for strengthening?
Well, I was talking about strengthening, but to maybe look at its role in overactive bladder. Have you found it to be useful for that?
Oh, yeah, absolutely. Absolutely, yeah, and that's probably where I've had personally the most success with patients. Right. Probably just because the patients that I've been seeing, but I think as an adjunct to everything else that we do, and certainly I would try it before suggesting that a patient went and saw their GP about going on medication for sure. So again, cheap, easy, non-invasive, and if it works, it works, and in a lot of cases it will work. So and as I said, we can work with it with fecal incontinence as well on very similar settings. And traditionally a lot of physios have only used it for stress incontinence based on trying to strengthen the pelvic floor. If the patient's got a 0 to 1, Moss grade of pelvic floor. Mm-hmm. But I think we need to be looking at it a little bit further. I've used it very successfully on patients who've actually got a contraction that I know I can palpate, but then I've got no idea that they can do it. So those patients where you think every cue that you've tried, it's just not working. They bear down when you say contract, they contract when you say relax, etc. It can actually give them that sensory motor input to this is what it should feel like. Absolutely. And then they can get to the point where they take over. And I think a lot of people use it as a last resort. We've tried everything else and nothing's worked, so let's have a little bit of stim. They do it for a week or two. Things aren't necessarily improving, so they go, I'll put it in the cupboard, that doesn't work. The research shows us you need to do it for 12 to 16 weeks to get a good effect if you're looking at strengthening. If your parameters aren't working for you, change them. Just because a lot of them are set at sort of 40 hertz for stress incontinence or strengthening. You're hitting up your fast twitch fibers there. So for some people that's not working, it's not comfortable. Patient says it's not comfortable, so they stop using it. You can drop your hertz back, drop back to 20 where you're looking more at your slow twitch fibers, and then you can gradually build up from there. Exactly. One of the big questions I get asked, they can't feel it. You're turning it up. Oh, they get it up to 20 and, nothing's happening. It's like these machines go up to 90 to 100 milliamps intensity. Yeah. Don't be afraid to gradually take it up until you get a contraction. So, there's I think there's a little bit of misunderstanding, a bit of fear around using it as well, and an expectation that, if it hasn't worked in a week, then it's not going to work. So
changing our expectations.
My big thing too, and what I'm sort of incorporating in. Sorry,
no, I was going to say, because oftentimes patients they will get impatient that if it hasn't worked in a week, or physios can get impatient, but we would think nothing of being told that a medication takes 6 to 12 weeks to be effective. And I think if we kind of look at the dosing for electrotherapy in a similar light, I think that would give it more of a chance to shine.
Absolutely. And also, we give pelvic floor exercise programs, strengthening programs. That doesn't work, in a week. You've got to be doing that for sort of 3 to 6 months for a strength program to work as well. You get those basic sensory motor and neuromuscular changes in that first couple of weeks. And that's been well researched. And, a lot of that is just tuning into what's happening. And if you've taught someone, for example, the knack, that will help them. But it's not going to build up the strength that we need to get that nice, strong, supportive levator plate to take them forward. So, it does take time. And I think, we need to be looking at managing those parameters and encouraging our patients and keeping them motivated. And again, I'm not saying that every patient needs stim, but for some, it can work really well, and I think we need to lose that fear of using it and learn how to use it properly, basically. So and my big thing, and I'm in the middle of developing a whole course on this, just because I'm constantly asked, and people saying, when are you going to run a course on this? So it's on its way. Is I've looked a lot into the functional electrical stim research. And I think that's the missing link. We use it a lot, say, for stroke rehab where, you know, they'll use stim to get muscles moving, and then they actually replicate that, doing ADLs, etc. afterwards. We put a stim machine on a patient, you know, do it 20 minutes a day or 20 minutes every 3 days, whatever, and wait for something to happen. You know, you've got to make that functional. You've got to, you know, improve that neuromuscular control, and you've got to, you know, get them using the muscles the way they're meant to be. And you've got to understand that a stimulated muscle contraction physiologically is quite different to a voluntary muscle contraction. So we've actually got to marry the two. If we're going to use stim as a treatment modality, we have to cross over that line to make it functional as well, so that we get that integration.
Yeah, so you're not just lying on a bed, putting in your stim machine for 20 minutes, and that's your treatment done. It has to be functional, real world, applicable.
Absolutely.
I wonder, Fiona, then, you know, to kind of take it through to the other end of the spectrum, if we're using stim for proprioceptive stimulation, for actually starting to get, you know, those proper contractions and then working with the contractions, if we go right the way through the spectrum, then what in terms of evidence do we have for looking at vaginal weights, you know, in terms of building up the levator bulk, you know, the levator plate itself? Because I think this is an area that a lot of physios are scared about, that they'll end up with overactive pelvic floors, hypertonic pelvic floors if they put a weight in. And I think, you know, there's been a lot in the press, hasn't there, over the past, you know, year or so, with jade eggs and different things like that, and putting in something and leaving it in there all day. I know this is something that you talked about very eloquently at Woman on Fire earlier this year. So I wonder if you could just, you know, just share one or two of your insights about the appropriate use of weights. When is it a good idea? When is it not? And what are the benefits?
And again, I think that comes back to functional activity. So I think we need to be really looking beyond that lying on the bed 3 sets of 10 3 times a day, which is just not functional. Absolutely, you know, maybe some isolation to start with to make sure that, you know, you've got the action correct, but we've got to then turn that into functional activity. And I think once we get our patients to a certain point, we're not great at taking them the rest of the way. And also, I think, you know, certainly that fabulously, that pendulum is starting to swing again, where people are starting to look at function. They're starting to say, well, hang on, these women can run, they can lift weights, they can do these high-level activities, as long as we support them through that, teach them how to do it properly, control those intra-abdominal pressures, etc. Absolutely, there's going to be women who can't do these activities due to whatever pelvic floor dysfunction, you know, they might have, like a bilateral avulsion, etc. But there are a large number of women who I think we do a disservice to, because we give them 3 sets of 10 3 times a day and say goodbye to them. And certainly where weights as the biofeedback tool can be brilliant once you want to take that next step. I did a podcast with Laurie Fauna a couple of years ago on weights, and went into that whole progression thing and the whole, like, looking at things in perspective. You know, we're not talking lifting surfboards like that. I can't remember the name of the lady who travels the world.
I know what you mean.
Pineapples and surfboards with her vagina. But, you know, we're talking in you know, very small weights. You're looking at, you know, about 40 grams. And if you look at the weight of a full tampon, or the weight of a pessary, for example, you know, we're not talking anything much heavier than those. So it's more of a proprioceptive thing. And you can certainly get people doing functional activities with a small weight in, and it gives them that feedback as to when they should be controlling their intra-abdominal pressure. So, you know, for women who breath hold and bear down, they might be doing a brilliant job lying down on the bed when you examine them, of getting a great contraction. You put them upright and start lifting a weight or a washing basket or whatever, and they might be, you know, they've got that poor coordination of diaphragm, pelvic floor, poor coordination or control of intra-abdominal pressure. So they can actually be really good. It's only a small weight. If you don't hold it in, you're going to feel it starting to come out. So it gives you that cueing as to getting that coordination, that control of intra-abdominal pressure. And you can take that right through to the level of going back into the gym, etc. And, you know,
well, I think
we're not talking about keeping them in all day.
Yeah, I mean, I think particularly for our postnatal athletes, you know, that we're trying to rehab, I think kind of that's a really good example because, you
Mm.
know, if we're talking about somebody who's delivered a baby vaginally, you know, the pelvic floor, I think, and you know, Nat McConaughey, I thought it said it very well a couple of weeks ago. Your body's never going to be what it was before. It's changed. It's different, you know. But what can we,
Yeah.
you know, this is where we are
Mm.
now. Moving
Mm.
forward, how can we really optimize functioning of the pelvic floor in the context of everything else? So I think kind of, you know, dealing with any obviously continence
Mm.
issues, you know, using things like the pelvic floor educator, stim, to start getting those appropriate contractions, but then
Yep.
taking it the whole way through, because we are still talking about striated muscle, you know, if we're talking about pelvic floor muscles. So we wouldn't just do
Absolutely.
empty
Absolutely.
bicep curls, you know, if we were going to expect to be able to load those muscles in terms of returning to sport, you know, or so I really just think it's I'm so glad that you've done this deep dive and that you've looked at all the research around weights, because I think a lot of people are scared of them, and I think they can be a really, really valuable
Oh,
tool, particularly
absolutely.
for sporting
And
athletes.
you know, yeah, and again, you know, they're cheap, they're easy, they're okay. They're invasive. You put them into the vagina, but you know, you can do no harm. If you can't keep it in, you can't keep it in. You're not going to, you know, when we're not talking about wearing them all day. And you know, unfortunately, there are a few companies out there who advertise their product as being something, put it in at night, wake up in the morning, and you'll have a sparkly pelvic floor.
Mm-hmm.
I have a big problem with that as well. But you know, there's two ways you can use them. You can use them as biofeedback, and you can also use them to build up endurance. So you know, you're looking at that 15 minutes hold, building up to say a 15-minute hold. And interestingly, the research that's been done on weights, they're all very similar programs. In fact, there's if you look at that in the Cochrane reviews compared to pelvic floor muscle training techniques or programs within the research, it's far more consistent with the weight research, as in doing very similar protocols for it. And there's a couple of really good studies, and as you know, my favourite one is the Porter-Rhoda one from 2015, which basically used a single sphere. Outcomes at 6 months to the group that were using spheres and not using spheres were exactly the same, but the sphere group got there in 1 month. So, you know, if you've got women who are wanting to use something, then why not offer them to use a weight when we know that they can have beneficial effects from it? You know, and the often referred to Cochrane review that Herbison and Dean did in 2013, and I think I wrote it down here. You know, the outcomes of that was that, you know, there was, I do have it written down here. Hang on a sec.
If you send me over the reference afterwards, I'll put it up in a little.
I'll send the reference over to you. Basically, you know, there's no real, you know, when vaginal weights were, this was a conclusion, when vaginal weights were compared to other treatments such as pelvic floor muscle training without weights and e-stim, no clear differences. But most people tend to quote that there's no added benefit or it's not as good as pelvic floor exercises. But, you know, if we're looking at similar outcomes, why not ask your patient, you know, we can get a similar outcome if we use stim or weights, or you can do pelvic floor muscle training. I mean, some people would prefer to use a device. Absolutely. So, you know, yeah, absolutely. I think we should be at least offering our patients that we have these alternatives. It's not just all about pelvic floor muscle training. And again, you know, the comment you made earlier, Michelle, about, you know, striated muscle, you know, my belief is that we should be treating it as such. And, you know, this whole do a set of 10 at the red lights and do a set of 10 whilst you clean your teeth. I mean, you're not going to build muscle bulk and strength, you know, doing them randomly throughout the day. Certainly, you know, doing some random ones, you're going to get that neuromuscular patterning happening, you know, but it's more for when, I believe, when keeping them working at the right time. But if you're wanting to bulk, and we want a nice, strong, bulky levator plate to provide support to the pelvic organs. Hello, there it is, yeah.
But Fiona, so can I just
so, you know, and the other really, you know, without going into
it. Sorry, we have a little bit of a delay, so we're crossing over. How important is it to do an internal pelvic floor muscle exam before prescribing weights in terms of, say, gauging for any pelvic floor muscle overactivity or any lack of coordination? Do you feel that's important?
Yep. From my personal view, absolutely. I mean, you know, I would never treat a patient without doing an internal anyway, obviously with consent. But, you know, I think you need to know what's happening in there, and you need to know, you know, have they got an avulsion? Have they got weakness? Have they got overactivity? I firmly believe that you can't tell that just from doing an abdominal ultrasound, because you've got no point of reference. Certainly transperineal, you've got a much better idea of what's happening. But yeah, look, personally, I believe you really need to be doing that internal to be sure.
Yeah, absolutely.
As to what's happening, and then you can, I mean, that's what we do as pelvic floor physios. That's when we gauge our treatment program and make our recommendations from there. But sure, I mean, if you've got someone with a hypertonic or high overactive pelvic floor, no, weights are not going to be their treatment. But, you know, that's using your clinical reasoning skills to then decide. And, you know, that's another big thing. I don't think there's any cookie cutter. I often get asked this, what's the protocol for this? What's the protocol for that? You learn clinical reasoning at uni for a reason. And I just really firmly believe that, you know, you use that clinical reasoning with each and every patient. So, you know, there's no cookie cutters here, but certainly here are some modalities that we can add into our programs. You know, there are circumstances when we can try stim. There are circumstances when we can progress people with weights, etc. And so I think we had a bit of a crossover there where there was a bit of a dropout with the internet. What I was going to say, there's some really, really interesting research that came out in the mid-90s, and you know, another one of my favourite is work by Deendall, where they really looked at, back in those days, they had very willing participants. I don't know if you get away with it now, but they actually did needle EMG into the pelvic floor and looked at, you know, what happened when with and without the weight in situ, and they saw this sort of crescendo decrescendo effect of the pelvic floor. So people think you're putting it in and the pelvic floor is going to sit like this until it comes out. There's actually this sort of contract and relax and patterning that happens within, dependent on loading. And they did actually show that putting a weight in could actually improve that patterning in women who were postnatal. So, you know, it's really some really interesting papers there. So again, that's a whole area that I'm kind of bringing into that course that I've sort of been looking at developing with all of this. Yeah.
So just to kind of wrap it up and put it all together, what you're saying is clinical reasoning is important. Understand the science of how these modalities work,
Absolutely.
whether we're talking about TENS for pain relief or stim for muscle contraction or weights for hypertrophy of muscle. Do a good assessment, use your clinical reasoning, know the science behind why you're doing what you're doing. And can we possibly persuade you to bring this course over to this side of the world when it's ready to go? That's my final question.
Well, you know, I'd love to come back home again. So absolutely. I'm really hoping to have it up and running for next year. And we're looking at, you know, doing it around Australia, but more than happy to come across the ditch and visit you.
Excellent.
And yeah, I'd love to.
All right, Fiona, as always, thank you for sharing all your knowledge. Where can people find you?
Well, hang out at my website, www.pelvicfloorexercise.com.au. I'm very active on Facebook as well. We've got Tip of the Day running again at the moment, which has proved really popular. So same Facebook page as Pelvic Floor Exercise. Occasionally on Twitter, probably not as often on Twitter as I was a while ago, but I pop in and out there at Pelvic Floor Exer. And Instagram too. So again, Pelvic Floor Exercise. So I enjoy hanging out on Instagram, and we've got a few new of the pelvic organ stories are progressing at the moment. We're up to number 3. So yeah, so there's a few more of those in the pipeline as well.
Fabulous. And of course, all of these products are for sale at pelvicfloorexercise.com.au. I have to say that the feedback that generally I hear from people who have bought from you, and I've been a purchaser, even though I'm here on the other side of the world, I still shop from pelvicfloorexercise.com.au, because in terms of customer support, but also the clinical insight that you can give is really second to none. So thank you for all you do, and thank you for sharing your knowledge with us so generously. And yeah, we'll see you on Facebook.
Thank you for having me. Nice chatting.
Pleasure. We'll talk to you
Okay.
soon. Thanks, Fiona.
Bye.